Our first speaker, I think he's ready, is Dr. David Levy. Dr. David Levy is a professor of oncology at Georgetown University. He is also the principal investigator for CAsToR at Georgetown. Dr. Levy has published more than 350 articles in renowned journals such as the American Economic Review, JAMA, the Lancet, and BMJ. He currently oversees the design and development of the SimSmoke tobacco policy simulation model, for which he has developed models for over 40 countries, covering 85% of the world's population. So without further ado, let's welcome Dr. David Levy for his talk.
Thank you, Ruoyan. Much appreciated. And thank you all for attending today's seminar. I've enjoyed it so far. I hope all of you have also. So first, no conflicts of interest to declare. I am funded. This project was actually funded primarily through my ITC grant, although also it was done a couple of years ago, 2 years ago, the paper I'll be presenting. But I also received funding through the TCORS and through an NCI CISNET grant, my other two major grants. So today, I'll continue the discussion related to FDA's proposed lowering the nicotine content of cigarettes, VLNCs as I'll be calling it, and lowering it to a minimum addictive level. And as has already been mentioned and described, FDA has already done their own project projecting forward the impacts of a nicotine standard. This presentation takes a different approach. It looks at what would happen if the industry had implemented a nicotine standard in the past. And it will also show how the impacts would have depended in a major way on time of implementation. The presentation's based, as I mentioned, on a paper published a couple years ago. And here's the reference if you're interested. Okay. So the paper itself had two main aims. First, we wanted to establish that cigarette manufacturers had the technical capability to reduce cigarette nicotine content. This follows the earlier discussion by Mitch Zeller, which showed that they knew that this was important, and they knew how important it was, and they could have done something about it, but they didn't. And then I'll provide some modeling to show the public health benefits from not implementing a standard at various points in time. So those were the two aims of the paper. The aim today, and part of why I felt that this presentation could be helpful is it provides, I think, important evidence about the impact of a nicotine standard. And, there's something we apply a lot in CISNET, and that is comparative modeling. Models all have different structures and sometimes different outcomes, but to the extent that models show similar impacts, it provides stronger and stronger evidence. So hopefully this modeling is something that's useful to the FDA. And Mitch Zeller also pointed out that the industry is likely to challenge a nicotine standard. If they do, this paper kind of throws back at them, you could have done it yourself. Why didn't you? And look at what happened as a result of your not doing this. It's a kind of could have, would have, should have approach to the topic. Okay, so as I mentioned, our first aim, and I'm just going to discuss this briefly, but there's a more extensive discussion, tables and so on in the paper to assess when manufacturers had the technical capability to lower nicotine in the tobacco used in cigarettes. We conducted a review of public patents on nicotine removal in tobacco and internal company business records assessed from the Truth Tobacco Industry Documents website, which is housed at UCSF. We found that patents and internal company documents dating back to the 1920s and 1930s, which describe methods to extract nicotine from tobacco. Clearly, the cigarette companies had the capabilities dating back to 1964. And I use that date because that's, of course, the date of the famous Surgeon General's report. Okay, so getting to the modeling. The modeling is initialized in 1964, and we initialize it in that year because of data provided from CISNET, our CISNET lung group, on separate prevalence rates, initiation rates, and so on, that enable us to distinguish trends in never current and former cigarette smokers. The data is from NHIS, so the longest available data set and one that's been relatively consistent over time. And we used, that data was used to project smoking rates forward from 1964. CISNET applied an age, sex, and year-specific initiation, cessation, and mortality probabilities developed by applying an age period cohort statistical model to the data from the 1965 to 2018 NHIS. And and this, was mentioned before, some of the work, the disparities work that's also come out of this kind of analysis. And I would emphasize, we often think of age and period, but cohort is really important because the circumstances affecting youth through time changes, and that comes through in cohort effects. Initiation from that data is based on respondents' stated ages of initiation. Cessation is measured as the percent quit from smoking for less than or equal 2 years to approximate cessation net of relapse. Models get very complicated when you try to model through former smokers and health impacts over time. So this method is a simplified method, which effectively looks at the trade-off of people who have not quit for 2 years as offset by those who would have relapsed after 2 years, based on studies and so on. The initiation cessation probabilities were validated by comparing projections from the 1965 to 2018 against, these are projections were validated against the actual NHIS smoking prevalence rate. So that was kind of a double check. And that gives us the percentage of never current and former smokers each year based on the various probabilities. And again, this is the status quo. This is based on what happened given many things, including policies and so on. And so an important assumption in this model is that we're trying to capture the many things, including the many policies, through this relatively sophisticated method. Okay, so we have the status quo. To look at the impact of a paper, of a nicotine standard, we need to then model the impact of nicotine reduction policies. And for this, we relied primarily on the Appleberg New England Journal paper because of the sophistication of the expert review that was done, as well as other information which they used in developing their model. Mitch Zeller talked a little bit about that before, and as he mentioned, they used an expert elicitation technique, a very useful technique, especially on issues where, you know, there's variation in how different experts view the impact of a particular policy. And what they got were the impact of a standard if it were to be adopted on initiation, cessation, and product switching. And it was taking into account, and this is an important qualification, which I'll come back to later, they did take into account other product use. In other words, switching to other products. We rely primarily on their midpoint estimates as the most plausible parameters. We also use their 25th and 75th percentile estimates for lower and upper bounds to develop the initiation and cessation multipliers. So basically, here's our modifications to the initiation and cessation probabilities that were in the status quo model. Status quo, everything's kept at 100% by definition. Looking at our midpoint evidence, and an important distinction we make here is differential impacts in the first year and in following years. And that's important because in general, I mean, you see this with policies, the biggest impacts are often in the first year, or maybe in the first couple years, but we model it into the first year for simplicity. But I don't think that in itself is an important assumption. So, and in case of initiation, you see that there isn't too much difference. In other words, the impacts occur directly on initiation, so they carry through time. In a sense, the important and more immediate impacts, especially impacts on public health, are through cessation. And here there is a difference. We expect that more people will quit in the first year. And so we use a 6 times or 600% multiplier to the status quo cessation probabilities, but it's lowered in the following years. And we also continue this through time, and by age 65, we allow for lower rates in following years. And as you see here, we have lower bound estimates, and notice here the lower bound estimates imply less of an impact on particularly the initiation and cessation probabilities. The upper bound impacts imply larger estimates on the status quo initiation and cessation probabilities. Okay, so what we did is we ran this analysis through 3 different dates, 1965, 1975, and 1985. Based on that, we looked at the difference in smoking attributable deaths using very standardized measures. Life years lost is also developed by CISNET. And this was based on mortality rates that were very carefully developed by the CISNET group. And we looked at the difference in smoking attributable deaths between the status quo, or really the very low nicotine standard scenario versus the status quo. And we also looked at life years lost as the difference between those two major scenarios. And we conducted this using the variation in parameters so we could do sensitivity analysis. And we projected this over a 100-year horizon so that, in effect, even the 1965 impacts have small but still continued impacts that continue through the current year. And we then sum up the impacts by year to get the cumulative public health impacts. So first, I'm going to show you the results when a nicotine standard is implemented in 1965. Okay, and first, I look at the status quo and the current smoking prevalence. In other words, the prevalence of current smokers. And what you see here is, if you go back to 1964, smoking rates were about over 55%. And they declined quite a bit over time due to the policies, which are implicitly incorporated through the methodology. And by 2015, the rates were at 20%, which is not too far from the actual rates. And these are, I forgot to mention, but these are for males. We also have the former rates and the smoking attributable deaths and life years lost, which are quite substantial, you'll see, over the time period from 1964 through, actually here we did the analysis through 2015, even though the model projects into, it does go to 2064. And as you see, the cumulative impacts under the status quo were 26.5 million deaths, but 300 million life years lost. Now we turn to the very low nicotine standard, our midpoint estimate, and you see that the smoking rates would be substantially lower, effectively 1/5 at 4%, 1/5 that of what it would have been in 2015, and fairly minimal, 1% by 2064. That's a reduction by around 80%, even by 2015 in the number of in the smoking prevalence. Also, you see substantially less smoking attributable deaths, about 14 million, and 184 million life years lost. I mean, still, that's a huge number, but it's about 2/3 what it would have been. And these are large numbers, but by any view from a public health standpoint. Now, with the lower bound, you see less of a I'm sorry, you don't see you see a smaller level of, seems like, oh yeah, lower bound. I think I have lower bound and upper bound estimates reversed here. I'll have to go back and check that. But because oh no, I'm sorry. we're looking at averted deaths here. So in terms of averted SADs, there are less averted SADs with the very low nicotine standard. With the upper bound, there's substantially more. I mean, we predict almost a 93% reduction in smoking and as many as 224 million life years averted relative to the 293 that would have occurred in the period from 1965 to 2064. I'm not going to run through the whole analysis for females, but you get similar kinds of analysis. The smoking rates are substantially lower, both beginning in 1964 and at 16% compared to 20% in 2015. But you still see similar in magnitude in relative terms, although smaller in terms of absolute numbers because of the lower levels of smoking. So,
2 minutes.
Okay, that was starting in 1965. Okay, so let's say it took a while till the standard got implemented. And so we ran analysis starting with the standard implemented in 1975 and also in 1985. And what you see here is that the status quo is similar, like it was before, but the impact is much less. You see. You saw, this is for males. Sorry. So going back, before we had under the midpoint, 184 life years gained effectively as a result of the standard. Here, starting later, we only have 142 million life years gained. And you see smaller numbers in the case of the female standard. Okay, so to summarize, first of all, based on our review, the cigarette companies had the capabilities of implementing a standard. They also knew the public health impacts by then of having these deadly cigarettes. So effectively, by keeping the nicotine, they were reducing the likelihood of people quitting or even starting cigarettes, and effectively denied them the choice towards something that was a less permanent alternative. And we showed from our analysis that there were substantial public health impacts of these decisions made by the cigarette companies. We also showed that timing is very important. That is, if they had implemented and they knew about the capabilities by 1965, if they had, there would have been huge public health impacts. Delaying it even to 1985 would have had still quite substantial public health impacts. About 211 million relative to 272 million life years gained. These numbers are even much greater than Appelberg, who is now looking at what would have happened now that we already have smoking rates at much lower levels. So if something had been done when arguably it should have been done, there would have been absolutely huge impacts. A response, if challenged by the cigarette industry. Some limitations, our effect sizes are based on the FDA expert elicitation, which has its limitations, including based on to a large extent. The cessation part is based to a large extent on clinical trials and with potential non-compliance, and also based to some extent on reported reactions by smokers who were asked how they would react. You know, some of the work that that Dorothy Hatsukami mentioned earlier in her discussion.
30 seconds, David.
Oh, okay. Clinical studies have not incorporated smoking initiation. And an important limitation is we did not consider substitutes. Now, implicitly, those are built in for the products that have been available through the years, although use patterns have changed. But e-cigarettes are not incorporated in that analysis. And we, as I mentioned before, we do not incorporate policies or counter marketing. So in conclusion, I think we've demonstrated large impacts. We've shown the importance of implementing this policy earlier rather than later, and we haven't even considered the potential from alternative nicotine delivery products if the standard were implemented in the next couple of years. Thank you.